This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This is our next to the last one of this year, and but today's a very special one, and it's one I've been looking forward to. Peter Wilson's going to tell us about Lipid Update, and as all of you know, Peter is probably one, if not one of the world's experts in this field. Peter's had an amazing career, launched out of Framingham, a long time a leadership role in the Framingham study, and is really one of the key players in this area. And every year he tells me more about lipids, new updates, new areas. And we were just talking, it's an area that sort of plateaued off for a while and then just exploded again in the last couple of years with novel drugs and some drugs that aren't working, and some that are working surprisingly well, creating interesting economic and ethical dilemmas as well in our practice. And it's an area of multiple different guidelines. You can pick the guidelines of choice and decide which ones, and whichever one you pick, your patients looked up the other one on the internet, and we'll share that with you. But it's always a great pleasure to have Peter update us on what's new in lipids in the last year. Peter.
I have no conflicts. So we're going to go through simple things and spend most of our time on the newer pharmacologic agents, because that's where you're all interested. A little historical background. You know, there's some younger folks in the audiences now who don't remember Mr. Fit because they weren't around. Mr. Fit took place in 1980. It was the largest screen group in the world for heart disease. We're going to try to outpace that in the next 6 months with the VA. They're not really screenees, but we have about 10 times as much data in the VA for middle-aged men, and to see whether these same gradients hold. And it's a J-shaped relationship as you go up. And even when you look at the top quintile, 244, you're not getting into hypercholesterolemia as we define it in lipiddom, so to speak, the top 1% or so. Now, this slide was developed by Don Lloyd-Jones about the time he was leaving Framingham going to Northwestern. And I find this helpful because this is a lifetime risk according to your cholesterol. And as you can see over in the far left, 31, 43, and 57% risk for a man to develop coronary disease according to three major cholesterol levels. So you say, you can quickly figure out I don't want to be in the back row on this chart because you've got numbers in the 50s and so to speak for the men in the high 40s even, 30 to 40 for the women. So these are the lifetime risks. There's a rule of 95 that I use for men. You may find that helpful in the clinic. So if somebody comes in and says, I'm 50 years old, am I ever going to get a heart attack? And I take 95 from his age, so if he's 50, that's 45 years. You've got about a 45% risk. It doesn't work so well in women, but it gives you a ballpark number for that discussion because you're going to have patients who are going to start to read about the lifetime risks, and you may not be able to carry those numbers as well in your head as the 10-year types of risks. Now, this is a 25-year follow-up by the Ansel Keys investigators. And it mimics the Mr. Fit, but it goes much lower, okay? As you can see here, low cholesterol levels, especially in, these are quartiles and quintiles. One of these lines didn't get connected for the Japanese, but you see the bottom quintile of Japanese, historically, very low cholesterols. And the top one there in Northern Europe is Finns. Finland has had great changes, however, since the 7 countries study. They really took this message of coming out of that study and the North Korea study, and they've lowered the cholesterol in the entire country remarkably over the last 25 years. This is an example put together by a Japanese investigator who got all the published data, now 5-7 years ago, and showed that, first of all, another message that you can tell historically, at least for your 55-year-old patient, good news, Mr. Jones, your cholesterol is probably going to go down if you survive. You know? And so you reach your peak cholesterol historically around 50 to 60, and then it goes down. And you can see this especially in Western populations such as the U.S. The reason he made this slide was because of all the China and Asian data, and China's still going up, and they have mostly younger populations. But in fact, I don't have a good follow-up for Ueshima's slide, but they're starting to catch up. The average cholesterol in the States has reached about 200, which is frustrating for our lab reports, because most people are above the mean, and patients read, I don't like this. My cholesterol I thought was good, and you say it's high. Well, that's because we changed what was a normal value, and we cut it down to 200 as the cutoff. But the Japanese are catching up to us. They're in the 180s to 190s range for the average levels. Now, I have to do some what I call general medicine aspects of lipids. Never forget about your secondary dyslipidemias. If you're going to be treating a patient in the clinic, the big one to screen is your chem profile and a TSH for hypothyroidism. You're pretty much done after that, unless you have something on the esoteric side. You don't have to go really any farther. Most of these other diagnoses that you can see here, you can pick up on the chem profile, and if the person has some unusual phenotype or looks different, or the numbers you just can't make any sense, get an endocrine or a lipid consult. Now this is the one, oh my goodness, slide on familial hypercholesterolemia, and I haven't updated it, I apologize, so we'll correct the things that have not been updated as we go along. Tendon xanthomas, they can occur quite early. 3-4-year-olds have tendon xanthomas. And where do you go for a tendon xanthomas in a youngster? You go to the Achilles tendon. They start to get very thick Achilles tendons early. They don't necessarily get them on their hands or the extensor surfaces, which are cold, that early. But they will get the Achilles pretty early. Homozygous, which is the 1 in a million, it's a little less common than that, more common, less than 1 in a million now. With the most recent estimates, they get premature coronary disease, and you might hear about that. That might be more of an esoteric, tough lipid question on a boards, is they get supravalvular aortic stenosis. They can stenose with calcification, mitral and aortic valves. The most famous patient in the history of ever having FH was a young woman named Stormy Jones, and she got the first simultaneous heart-liver transplant to give her LDL receptors. She was taken care of by Goldstein Brown and Scott Grundy, and she was put on cyclosporin and a statin. The statin worked much better once she got her liver. Remember statin, because the LDL receptors then get upregulated with the statin. But she died of a viral syndrome in her teenage years. Very unfortunate. Laboratory, as you can see, increased LDL. You can, throughout everything in this talk, you could measure total minus HDL, or you can measure LDL. Almost all the U.S. has been LDL cholesterol centric. Of course, there's some interest in LDL particles, but you can use total minus HDL, and don't hesitate to get the specimen in the afternoon for your patient. When they say, I'm not fasting, no, go ahead. You've got total minus HDL. Almost any number that you want to use, you can add another 30, and that will give you a feeling of where you are if you're not used to using the total minus HDL as a measure. So one of the corrections here is that it's about 1,800 possible mutations. This is an old slide I hadn't changed. It is more common in certain parts of the world. The South Africans especially have concentrated. You'll see a lot of leadership for the newest homozygous trials coming out of South Africa. And the diagnosis, you don't really need to do a genetic diagnosis. There's a variety of types of techniques, so to speak, using combination of lipids and physical findings. Most of us lean first, of course, on the lipid findings. But in the VA, for instance, they make it tougher. They want some of the physical findings as well. And then the therapy is virtually everything that we have. And you try to get statins for all of these patients. They don't work necessarily so well in homozygous, but you're going to be seeing heterozygous. So another little pearl. This is from Goldstein and Brown and the JCI in the early 1970s. If you walk in, at least in the 1970s, if you go into the coronary care unit and you started testing people at the appropriate time after they've recovered, what fraction of them have heterozygous FH? It's about 5 to 10%. So 1 in 20. So it's incumbent upon us, if the person's not on, of course, we're going to be putting them on a lipid medication as they go home because of all the data, ACS, et cetera, for secondary prevention. But think about the family, and it's a point, hey, have your children been screened, et cetera, et cetera? Have your first-degree relatives been screened? As you can see there, LDL apheresis in the homozygotes has been the sort of the leading edge of the toughest of the tough patients, but as you know, something like that is not available everywhere in the United States, so that has been one of the targets is for those homozygotes and also for some heterozygotes to develop new molecules. You have a patient in front of you and he has heterozygous FH or she has heterozygous FH. That's the most common one. So you'd be down here in the bottom. You have a heterozygote and they're most likely are going to have a normal other parent. And as you can see there, about half are going to be heterozygotes, half are going to be normal. So that question will come up. You'll have patients who will sort of say, and it's autosomal dominant. There are a couple of rare unusual types, autosomal recessive, but for the most purposes, it's autosomal dominant. Just think of it that way. So this is our xanthelasma. Can you see the little yellow spots, yellowish to orange, just below the medial canthal fold? They often get removed by plastic surgeons, and the patients don't tell you about it. We have one patient at the VA who they keep coming back. He's taking his medicine, and he keeps getting them removed. And so we always put the fellows in with him and say, hey, tell us what you think, and see if they even ask. Because most of us forget to ask, did you ever have them removed? He knows to play the game with us now, so he's quite supportive. Now this is Arcus corneae, which is the white ring. This one has very severe, it's almost total. It may be partial. But remember, Arcus corneae can go along with a few other diagnoses. Wilson's disease, not related to me in any way. Hypercalcemia, homocysteine elevations, things like that. It's not really very much help after age 30. And it occurs earlier in people with dark pigmentation. The dark pigmentation finding and acceleration to get it has been noted mostly in American blacks. I don't know whether people, for instance, South Asians and others, dark pigmentation get it earlier. Somebody ought to do that. I haven't seen a paper on that, though. Now, these are tendinous xanthomas. This is a commonplace, and you may pick this up when you shake the person's hand. And don't just look for tendon xanthomas in the hands. Reach and feel on the hands. And they are not in the joints. They're not in the knuckles. They're not rheumatoid arthritis. There are a bunch of things they're not. But get used to feeling for them. So some of these newer medications, they go away. In fact, if you get the teenagers and you treat them with these very aggressive newer medicines, they go away. But once they get calcified, you can guess it's a lot harder to have them go away. See, now there's an example one a lot less severe. You really have to feel those. These are the determinants. In addition to the secondary dyslipidemias, we have dietary. Now there is some good news here. I don't have data on it. Less cholesterol in the diet. So when I was in training, we used to talk about a couple of eggs a day was worth 10 milligrams of cholesterol in your blood. That's been thought in the most recent review analyses to be an overstatement. So your patients can eat eggs. Now that doesn't mean they can have 6-egg omelet every morning, but they can eat eggs and you don't have to be so tough on them. The biggest issue is saturated fat. Polyfat probably undoes some of that. Remember, oleic acid, olive oil as a fatty acid is a mono, so it's not in either of those groups. It's sort of right on the balance beam, so to speak. So just I think we all know the general message is fewer calories and fewer percentages for saturated fat. Most of the diets are similar. You'll have patients who will come in and say, oh, I'm following the American Heart Diet, and the next person will say, I'm doing somebody's diet like the Zone diet. In fact, if you start matching up, many of these popular diets are pretty similar to the American Heart Association diet. They just have a little twist. They have some names, advertising. You know, the tougher ones, the ones at the extreme, South Beach is more extreme. And the other one is Pritikin types of diets and Ornish diets are at the extremes. But most of the popular diets are closer to the American Heart Association types of diets. Estrogens, so you'll have a patient, you might not see this patient, but you may hear about it. A woman says, I started taking oral contraceptives and my lipids went way up, especially my triglycerides went up. What should I do? And she should go see a gynecologist and get a lower dose estrogen in her product, or find another way for contraception. So it doesn't happen in all women, but it is an association. And women, as they go through the menopause, they lose that estrogen effect as well. So estrogen has both LDL and HDL effects. That's part of what happens as women go through menopause to increase their risk for heart disease. Bad changes, not so severe in both, but bad changes in the wrong direction for both LDL and HDL. Now, it's Monday morning, here we are. It's time for molecular biology, okay? I told Bob Taylor we're going to have some molecular biology here. So we all remember this, I know. It's how we make particles. And starting with microsomal transfer protein, you go through the Golgi, you create vesicles, and what leaves the liver is the factory for these particles. What leaves is a VLDL particle. It goes out, it hands off some of that to LDL, through cholesterol ester transfer protein and others, and then it comes back as an LDL, and that's in the top right where you're seeing number 4, and it goes through the coated pits, and there's a receptor there, and this is what Goldstein and Brown are famous for, in fact, describing the molecular biology, sequencing the receptors, etc., comes back in and gets degraded. And we're going to come back to a little bit more of that mechanism. So first is the statins. How do the statins work? The statins, what we learned in biochemistry is they work early and they affect HMG-CoA reductase and decrease synthesis. But in fact, their major effect is to upregulate the number and mostly the function of the receptors, as you see up here in the top right. Okay, so that's a good question always to ask the fellows when they're around with you. How do statins work? Because almost all of them just remember the primary mechanism, but the receptor mechanism is probably more important. Now, this will help you. This slide is put together by a variety of people. It was a safety slide in terms of LDL reduction with the different molecules and liver abnormalities. We don't get too concerned about LFTs in 1 or 2 times upper limit of normal, 3 or more for LFTs, different for CKs. But as you can see there, let's take one that got a lot of safety data. Rosuvastatin, this is from the Jupiter trial. As you can see, very high levels across the 4 doses. That's what each of those points is on the curve. Each of the doses, even at highest dose, not much trouble with rosuvastatin. Atorvastatin, you see a signal there on the top right. Similarly, you see the signal for Simva on the top there. As you remember, Simva 80 is no longer available for prescribing. Right? So that's what it is for liver function. Now this one's more dramatic. This is for CKs, and this was when Serum was being marketed, and there were major concerns about Serum. And the top dose, as you could see there, was pulled, and the drug entirely was pulled shortly afterward. For most of these others, you just don't get above what I call the 1% rule, and the 1% rule is on the y-axis. That means of 100 people, what fraction even get their CKs greater than 10 times upper limit of normal. So it's much less than 1%. Some people would, the most recent estimates say it's less than 1 in 1,000, maybe more in the range of 1 in 10,000. But it's certainly not that big an issue. You're going to have some patients who are going to get into trouble, though. And the dark urine, the runners who go out and jog, don't drink water, etc., older women, a whole variety of different groups who can get into trouble with very high CK, and you can get rhabdomyolysis. Leads to emergency room and a hospitalization. Simvastatin warnings. Every cardiologist should be aware of this. And so I have a rule of thumb is for a patient taking cardiovascular drugs, I really avoid a high dose Simva, which is tough because they have heart disease, and you want to lean towards a high potency statin. So Simva at its top doses is a high potency statin, but that's why it's not in that list that came out for the 2013 ACC-AHA. It's not in the list because the highest dose of Simva 80 was associated with increased rhabdomyolysis in the SEARCH trial, which was a huge British trial about 5-10 years ago. So as you can see, calcium channel blockers, verapamil, diltiazem, and then as well amlodipine comes in. So you have to dial down the dose. Well, think about this. That can be a problem. So you're seeing a patient and you start him on Simva 40, he's post-ACS, and he's not on any of those medicines. And 2 months later, your colleague got patient, different venue, he doesn't have all the meds in front of him. That's why reconciling meds is important. And then next thing you know, he's put on diltiazem and you say, whoops, and he starts to cramp up all over. Well, you could have probably avoided that and then reach for something other than Simva 80 for those patients. This other little comment down here at the bottom was a signal that was seen in the combination trial that was Lomitapide, which is no longer available, especially Simva-niacin in Chinese patients. Now, does it work? This slide is to give you a feeling for the types of numbers. What do we tell patients when they're in front of us? And I use 3 or 4 numbers. So for death, some people say, well, are you going to save my life if I take this medicine? And the answer is it's around 15 to 20%. And you see in the top red there, 0.86, so a 14% reduction. But for some of the events, you're not going to prevent. So you say, what crosses that line in the middle? Ischemic stroke, hemorrhagic stroke, stroke overall. And it's especially hemorrhagic stroke. Think about it. You're trying to change atherosclerosis, and it's not really related to hemorrhagic stroke. So it doesn't work there. So secondly, when you get down to non-vascular causes of death, that's not where it works. It's really a cardiovascular preventative agent. Okay. Now, the overall number is this one. This is the CTT meta-analysis, the cholesterol treatment trial list. Out of the Oxford group in England. Those are the people who invented the meta-analysis, and they're still doing it. Richard Pito is the leader of that. And the number way down at the bottom there is 0.78. And I use that number a lot in front of patients. I say, you're taking this medicine versus not taking it so that you'll get a 22% benefit compared to somebody who's not taking anything. And then at the very top of this were the trials that were premised along the lines of high dose versus lower dose. Remember, we went through that era for a while, and it's similar there. If you may benefit from a higher dose, you really ought to take the higher dose. What we don't know is whether the low-risk person, the 35-year-old person who maybe has one risk factor, it's just squeaking over criteria, should that person take the highest dose? We don't have data on that because we just haven't done the trials. All right, and then this other from that meta-analysis is there are lots of figures in this meta-analysis, but just look at this figure at the top of this, more versus less statin, according to international units, less than 2 millimoles is 80 milligrams per deciliter for your LDL cholesterol. As you can see, that person benefits. So that's another simple message. And don't bargain with your patient. Okay, you had ACS, you had an MI, but doctor, I have a low cholesterol, I don't need to take this. You should take the medicine. You're going to benefit. And this is the supporting evidence for that. And remember, you're not just working on LDL, you're working on anti-inflammatory pathways and other mechanisms. So this is another message. So unfortunately, we'd like to have a lot more data on that, but it's the rationale behind even patients with relatively low cholesterol for secondary prevention, they should be taking a statin. Now, this is one of those laundry list slides. I apologize, but it's helpful. And you can sort out where there's the major effects, and we really just went through most of those. Minor effects, at least one cancer signal, but more in the center of this slide are the no effects. Cardiac failure doesn't really help, especially if the person doesn't have athero as the cause of the failure. They have hypertension or they have cardiomyopathy, for instance. It doesn't help for calcified tissues, calcified valves, calcified aortas. And also, your patient's going to say, I have a high coronary artery calcium score. My statin's going to really help. I'm sorry, it's not really going to do much there. It's going to prevent an event, and it may stabilize the plaque. And then he says, don't ask me what stabilization is. It's just not going to get worse, but it isn't going to go away, okay? And then also dialysis patients. What happens if you have a patient who has got CKDs, getting ready to go on dialysis, is on a statin? That's a question I often ask fellows. I said, do you want to stop the statin? So the person was pre-dialysis and he's on, let's say, 40 of atorvastatin. Do you want to stop it? Well, I don't know. There's no answer. And I said, you're right, there's no answer. But, if you think it's prudent to keep the statin going, sure, keep it going. The patient's going to be on a lot of medicines. He's a chronic kidney disease going on dialysis. What about the person who's 5-10 years post-dialysis, or a survivor on dialysis? Should I start a statin now? And that's a tough one, because that's where the trials took place and they showed no benefit. I don't know what to say. I think most of these patients in the modern era are on a statin if they can tolerate it. And you'll think of another reason, because he may have coronary disease. And remember that dialysis patients are due about the same as failure patients. The 5-year survivals, 50% or less, 7, 8, 9 years is typically as long as they go, and they're going to die of atherosclerotic disease or failure as the leading major cause, and sometimes it's hard to sort out. So that's a personal decision with you and the patient. And then you can see the increased risk. Diabetes, I think I have a slide coming up on that for that risk. That's what this one is. So your patients can say, it's all over all the lay magazines, the Time magazines, I'm going to get diabetes if I take it. Yep. And this meta-analysis was done a few years ago. This is by Naveed Sattar from Glasgow. And as you can see, it's a 1.09, so it's a 9% increased risk. And you have to balance that out. Okay, so Mr. Jones, we're trying to get a 22% for all comers reduction versus a 10% for that. And as Paul Ridker's group showed in the Jupiter as a post hoc meta-analysis, all of the metabolic syndrome components contribute to risk in these patients too. So if you have a person who is a metabolic syndrome patient and he's 50 years old, I think you're going to have a pretty easy discussion. You say, it's the metabolic syndrome components that are especially, you're going to be at much greater risk of having some early diabetes, but you're also at incredibly high risk of having heart disease. So it's a risk-benefit discussion. And we all have the background to do it. There's no rocket science here, no missing factor that you're totally going to be out with. Just concentrate on the metabolic syndrome types of things, and then your starting point is this 10% risk. So, all right, just more on that. Okay, statin myopathy. I mentioned some of these already. The greater age, sex, renal insufficiency, hepatic dysfunction. Okay. Oh, one other thing to come back to this. We do this in lipid clinics, and we don't know whether it's right or wrong. We screen everybody who has the muscle aches and pains with a TSH. And you fix you correct them, and if you can refer them to an endocrine to get that done. The other thing that you'll see in the literature, and it's pretty hard to sort out, is what about if they have low vitamin D levels? We fix that too. In endocrinology, we're very comfortable, and we do this all the time. Whether that makes a difference, there are some studies out there in the literature that suggest correcting the vitamin D will make the myalgias go away, but I don't know. I wouldn't buy that. The other thing is, remember, is the myalgias have no decrease in strength, and they really don't have increased inflammation. It's not a myositis. It's a myalgia. It just hurts. And Paul Thompson at Hartford is probably the best source to read about that. Done some trials with this as well. So we already done that. Okay. Can you figure out who's going to get the myopathy? Now, this is an exciting area. This is an older study, but we're going to be doing this in our VA. We have a large VA precision medicine grant that's going after elements of pharmacoepidemiology and genomics. Within that search trial, the individuals who had the CC genotype are the people on the top, as you see there. In other words, there are only 2% of them, but if you went out for 6 years, 20% of them were getting a very severe myopathy, not just a myalgia. They were getting the myopathy. And it was only at search was 20 of Simva versus 80 of Simva. And it was only really seen at the 80 of Simva dose. So this is a foot in the door for pharmacogenomics. And everybody's saying, hey, I want to look at every molecule in every trial. And now this group had this organized, but you're going to start to see more of this. Is this molecule, this marker, it's called, I didn't put it on there, but it's SLO1C1B1. And, but is that marker or other similar ones going to affect the high dose? Because almost at every highest dose of a statin, you have people who are going to get into trouble. So, and this is the only one. It's only Simva at 80. So, okay. CETP, I got to mention a little bit about that. So CETP, remember you're making a VLDL molecule, and then it's going to hand off and exchange lipids, and then the LDL molecule is going to come back, go to the receptors, and get degraded. So the idea, this drug not only lowers LDL, but it raises HDL. So this was the HDL mechanism everybody has talked about. We've all been interested in finding an HDL favorable drug, something other than estrogens in the premenopausal era. You know, natural estrogens, we know, have something to do with an HDL favorable mechanism, but is it CETP driven? So torcetrapib, which was developed by Pfizer, was the first in the class. The trouble was, as across the board, a 4 millimeter increase in blood pressure, and then hyperaldosterone, and the trial, the clinical trial was stopped early, which was Illuminate and Illustrate, which was the carotid IMT trial, was also stopped. It didn't work. It just didn't work. So there have been follow-ons. Dalcetrapib, Creton Mavromatis was an investigator on dalcetrapib. It also didn't work. And Anna is, I haven't seen the recent results, but it's apparently not working either. So we're going to have nothing anytime soon from the CETP arena. This is an example. Sek Kathiresan, who's visited here as a guest, Arshad invited him down. Sek is also, I'm on a grant with him through the Boston VA collaboration. Sek is one of the key leaders in the world to do genome-wide associations with lipids. And as you can see here, in the red boxes are the new findings that he found, at least in GWAS in 2009. And this keeps expanding. So this is about 35 or 40. We're up to hundreds of markers. And of course, the GWAS investigators are going to bigger numbers than 20,000. They're going across all the major databases. But you can see ApoE, some of these ApoB, LDL receptors, PCSK9, which we're going to talk about in a minute, tangiotypes, which are ABCG8s, and Niemann-Pick's. HDLs, you can see the big driver out of all this is the left-hand column, because most are of the belief that the greatest opportunities are of finding agents that are going to effectively lower LDL. Okay, so here are the new, at least I'm not going to have any other slides beyond these types of molecules here, but let me mention a couple other things. There's in the works as a dextrothyroxine molecule, a new congener. I don't know if those who are older than me can remember the Coronary Drug Project. The Coronary Drug Project, one of the drugs was D-thyroxine, along with clofibrate and other things. D-thyroxine was not a great drug to hand out to patients with angina because it caused increased heart rate. It didn't do anything for your thyroid because it was D-thyroxine, not L-thyroxine. And it caused angina, though. And so they're working on some ways to do that and to mitigate the potential heart rate and other adrenergic effects. And now I'll mention a few others as we go along, but there's a whole bunch of newer thoughts that are out there. Oh, well, yeah, one other one is inflammation. So anti-inflammatory drugs, and there's a large NIH trial. Creton's an investigator. The chronic inflammation reduction trial through Paul Ridker, and that's statin plus placebo versus statin plus methotrexate, low dose, okay? So, and it's a proof of concept trial that Paul Ridker has put through NIH funding to see whether reducing inflammation will favorably affect events. Okay, but now these new 3 molecules, and each one of these has gone through FDA in the past 2 or 3 years. And some of them are a mouthful. So MTP, you remember that one, mostly because the drug underneath it, Lomitapide, has an MTP in it, as you can see, for each of the sounds. The next one is an antisense oligonucleotide. So this affects the synthesis, so it makes the wrong ApoB. This is really brilliant sort of science when you think about it. We'll get to that in a second. And then the last one that just got approved last year are a mouthful, and I'm not going to, well, I will say it, why not? Proprotein convertase subtolin type 9. I practiced that. So that's why it gets called PCSK9. And there are two that have been approved, and there are others being developed. Almost every major pharmaceutical company has a drug or is partnering with somebody on these drugs. So now we're building on what we had for statins, and you can see here on the left side are two. We have the oligonucleotide, which is mipomersen, and then the MTP inhibitor, Lomitapide. Now think about this. This is supply side. So you're affecting the production of your VLDL molecule before it goes out. VLDL it's very low density. Fat floats. We can all remember that, right? That's how much we remember about some of our things. But VLDL is the lightest molecule, so it's the one with the most triglycerides. And if I do something and I don't let the VLDL molecule in development to get out of the cell, what happens? The liver cell fat, I get a fatty liver potentially. Yeah, that's right. All right, so we'll show you some data on that. And the first thing then you start getting into the discussion whenever you hear our fatty liver experts talk, is you start to see signals for ALT and AST. These are now been published, but these were from the FDA hearings. As you can see, ALT, AST going up, hepatic fat in the dotted line going up 8 or 9%. Not everybody gets it, as you're going to see in a scatter plot in a second. And these are 56, typically half-year and full-year studies. But here's more of an example of what happened. These are heterozygotes and homozygotes who are getting these types of molecules. So you get some people get up in 25, 30% fat. Many people stay pretty low, and then they track them over time using ultrasound types of things. Very few of these groups have ever doing, or MRI, or very few are doing liver biopsies. Okay, PCSK9. So PCSK9 is probably the most incredible story in the last 15 years for lipids. The people who get credit for putting it on the map, really, clinically and biochemically, are Jonathan Cohen and Helen Hobbs. They've both been awarded all sorts of prizes, lectureships, etc., through the American Heart Association. So this came out of the Atherosclerosis risk in communities. Now there are other work, but they showed, as you can see in the top there, if the person, no nonsense mutation versus the bottom line, the 33,000 plus, the bottom histogram is the 85 people with the variant. And you say, okay, those distributions are really different. And then you look at the average, the peak LDL is around 75. And then as you move over to the right, the people with the variant don't get heart disease. And this was picked up and sequenced around 2004, 5, 6. And everybody jumped on it who was a molecular, to make new molecules. And they said, could we take advantage of this mutation? So in fact, this is a mutation that could go the other way as well. It can be associated with very high LDL cholesterols. But wouldn't you rather have a 75 versus 130? Sort of like a 50% difference in your LDL cholesterol on the basis of genetics. And it was more common in blacks than it was in whites, okay? So it was picked up especially in the African-American component. And the African-Americans in the ARIC study are largely from Jackson, Mississippi. That's really where it came from. But they shared that data in the genomics of the ARIC study with Eric Boerwinkle at Houston. And Eric Boerwinkle then got involved with Helen Hobbs and Jonathan Cohen, who happened to be down the hall from Goldstein and Brown. a real powerhouse of molecular biology for lipid advances. Okay? Now this is homozygous. You're not going to necessarily see these. So these are different, but it shows you what happens if you had a homozygous. So a homozygote patient, Larry Sperling, I guess I saw Larry come in. Larry's got the only homozygotes in Atlanta pretty much. So most of you won't have that experience. But if you put them on a statin, they're going to get a statin as soon as somebody has the confidence to give them a statin. They're in their early years. Not probably in the first 2 years of life, but starting at 2 years on, they're going to be getting a statin plus everything else. Before then, and the reason is you don't want to inhibit brain growth and myelinization. Okay, but then they get everything. So you're going to, if you started out with an LDL cholesterol of 400 or 500, let's say, so you're going to knock down, each one's about a 25%er. So I'll knock them down to 300. And then I'll knock them down maybe to 200. So a 200 is where heterozygous FH starts. So is that good enough? Well, in fact, you'd really like to get the homozygotes as low as possible. The homozygotes, the average lifespan is now 35 years old. When I was in training, it was 19 or so. They'd all die of angina and coronary disease, MIs, in their teenage years. But now you can get, even in these folks, typically you'll get a 30%, has been estimated by Fred Ryle in the Lancet for this, but you'll get even more than that in your heterozygote or your other patients that we're going to see in clinic. So each of these drugs has added effects, okay? So this is the type of data that you get. These from the last few years from these efficacy trials. So these are heterozygous, LDLs typically, 190, 200 plus, and they're already on statin. So you've knocked them down. As you can see, they're on a statin. They're starting around 160. And then you add placebo versus 2 different doses they tested of a PCSK9 drug, and you're bringing them down another 60%, okay? So the achieved values are going down basically from 160 to less than 80, okay? Same sort of thing. This is and there are 2 or 3, this is hypercholesterolemic patients, not necessarily hetero or homozygotes. And these people started out with LDLs of 120, and they went down to 50. And for who has patients on PCSK9 in the room? Larry and I do. So I have one patient at 54 right now, and she was approved because she had so many problems, and she had rhabdomyolysis. So, but I mean, these are not uncommon numbers. You're going to get patients with these levels, okay? Now, what's happened is the experience was developed in hetero and homozygous patients. And if it had been done entirely in homozygous, they would have gone to the FDA for what is called an orphan drug indication. But in fact, they wanted a wider indication. So the heterozygous is sort of reaching out, but heterozygous, remember, is still 1 in 250 to 1 in 500 patients. So the companies that make this are looking, of course, forward to have a wider use of the medications. And they put together outcome trials. And these early outcome trials, this is from Jennifer Robinson from the ACC about a year ago. As you can see there is favorable effect for non-fatal MI, but look at the event rates, 0.9 versus 2.3%. So these are not real trials. These are sort of post hoc. They were safety trials looking at and then they got everybody together. So it's not the type of trial you're really going to make a decision on what I would call the everyday user of these medicines in the future. This is another one, similar one, as you can see here, showing lower levels. And then here's also within Osler, an outcomes trial and safety. First of all, the other question comes up is safety. These drugs are as safe, maybe safer. They don't tend to have the same sort of side effects, the myalgia as much, so it certainly is not a barrier. And the abnormalities for the liver and CKs is just not there. All right, so here's the Osler outcomes. Now, for those of you who read the New England Journal to look at trials, this is also instructive. The New England Journal is now requiring the y-axis to go from 0 to 100. And you see that over here? And so the results are down there at basically 2% versus 1%. And that's so that all of us, when we read the paper, have a reality check on what's going on. So that's what that is, and then you can explode the 1% versus 2%. You can't just show that little figure there as 1% versus 2%, because you get a false impression of big, big differences, and this is going to really help my patient. Well, this was based on a very unusual group of people, and they only had 1 year of follow-up. It would never be a regular trial sort of scenario. So, all right. So let me mention one other before we get into what happened with the FDA for this. So you should pay attention. If you have your LDL now at 50 or 25 to 50, and we've all heard that that's safe, you should at least think of some of the other things that might be associated with this, and they have been studied. The trouble, one of them is Abetalipoproteinemia, which is that first mouthful on the top, and then the other is hypobeta. The A-beta patients are, there are about 5 to 10 of them followed at National Institutes of Health. I was in that clinic and I saw some of them. Alan Romali and his colleagues are seeing those. They have to get vitamin infusions. They really can't absorb vitamins. They get liver disease, they get spleen disease, they get spinocerebellar degeneration. They get, because of the vitamin A deficiency, they get retinitis pigmentosa and night blindness. So vitamin K, A, D, E, remember all those are carried on your LDL particle. So for vitamin A, we have a backup. We have retinol binding protein. So vitamin A deficiency with very, very low LDL cholesterol isn't so much of an issue. But these others potentially are. And some of this we may sort out, but is this going to, we haven't seen much data on it, for instance. So can patients on warfarin take these drugs because of the vitamin K issues? Will they have a long-term effect on vitamin D metabolism and osteoporosis? Don't know. So they're going to need to collect safety data. I haven't seen anything for warfarin. Larry, do you know if that's an exclusion at this point?
It's not an exclusion.
It's not.
But your point is well taken.
Yeah. So, I mean, they're going to be looking for this. Everybody wants to know safety data because of the very low levels. So this is the actual language from the FDA after the advisory committee, and it was approved for heterozygous and homozygous. But then this was the one for greater concern for those of us as clinicians. People with atherosclerotic disease, such as heart attacks and strokes, who require additional lowering of LDL cholesterol. That reminds, it's like the Delphic Oracle in Greece, isn't it? You know, you go get an answer and you then have to think, how do I interpret that? And so that is the exact language. And there are several outcome trials in the works, so to speak. Here's the VA. The VA has a separate rule, and because these are expensive drugs, we'll get to that as the last slide. So in the VA for hetero FH, you have to be a specialist, and then you have to actually meet the laboratory criteria. You have to be on a high dose of Atorva or Rosuva, and then you have to be intolerant of these, et cetera. You can read through this. So they make it a lot harder, but then the medicine is approved by the pharmacist, and then it's a go for that patient. And they have to keep taking the drug, though. If they don't renew on time, they can get dropped from the list. And then homozygotic FH, there aren't very many homozygotic FH in the United States because they would have severe xanthelasmas going through teenage years and wouldn't be in the military. Similar, but they also have to have findings. So this is an example, the Fourier trial of one of them that is in the works. So you have to show benefit in the modern era on top of a statin. So you have a statin plus placebo versus a statin plus or nothing. It's pretty hard to have a placebo injection because these are every 2-week injections. A placebo plus the new agent. And for instance, ezetimibe as an added drug was part of the Improve It trial. That was their context. That went before the FDA panel last year, split the vote across the committee, and the FDA did not change the ruling on ezetimibe. So ezetimibe still says it lowers cholesterol, doesn't say it prevents heart disease, and it was not necessarily indicated on top of a statin, and that was what the FDA put in its announcement about 2 months after the meeting. The issue is you're going to have to do better than that, probably. That's why I'm taking the prelude for what happened with ezetimibe. So ezetimibe was LDLs of 70 that went to 55 over about 7 years, and then you get only a 2% absolute difference. And I'll show you those data in a second. You got to do better than that with these newer molecules. Or you got to take people who are higher than LDLs of 70, like 100 to 150, and then show benefits. So it's going to be a different type of scenario. So this is the last slide. All right, and this is a cost slide. And Bob even alluded to that. These new medicines are costly. The mipomersen and Lomitapide are also costly. Those have special training. They're targeted for homozygotes. These can be used in heterozygotes. Within the Emory Clinic system, our nurses will work with the clinicians. Larry has probably got the most experience, and our nurses are quite good with this, but it's tough. Each of these molecules was, as they first were approved, the companies were very interested, but now it's starting to click in, and we're in sort of what I call the 6 to 12 month, really sorting out whether the insurance is how that's going to go forward, et cetera, and whether your patients really meet strict criteria. So you can go through numbers needed to treat, and that's about 5 columns over, and I'll just give you the feeling, and we'll scan down then, and then we'll look at the costs. This is a complicated slide, but the numbers needed to treat in the Wascops trial, the West of Scotland, which came out many years ago, has been often considered one of the starting points. If you can get a 1 to 40, everybody wants to use a medication like that. And that's versus placebo. And then you go down TNT and improve it. TNT also, high versus low of ATARP. Everybody said, yeah, that looks good. But improve it, which I was just referring to, when you have only a 2%, but these are people who have already been knocked down with a statin. So it's statin plus a second molecule versus statin alone. That's been the only trial that's been positive with adding a second drug. So we didn't see that with adding niacin in the Lipoprotein trial or in AIM-HIGH, and we didn't see it in Accord, which was statin plus fibrate. So this has been the only positive trial, and then the FDA really didn't change any of the rulings for this molecule, for ezetimibe, for instance. Here's an example where we are with heterozygous, and again with 2 trials with Odyssey and Osler. And the point is we're higher than that on top of a statin. So the current trials don't provide the answer, and it's very expensive to prevent events, as you can see. That's annual cost per event prevented. So that's where we are. I think we need to see what happens next with these Fourier trials and the others to see really where it's going to sort out. So thanks very much.
Thanks, Peter. That's fantastic. So a lot of potential questions. I'll start out with one that came up to me in clinic a couple of weeks ago, and it's one that comes up frequently. I tend to see a lot of faculty members here at Emory, and the biggest push I get on statins is the whole issue, which I thought had sort of been put to rest, which was the potential impact of statins on long-term cognitive function. And maybe if just the words from the experts on that would be helpful, but I still run into that very, very frequently.
Yeah, so the question is whether there's decrease in cognitive function. And so far, the data have shown a null effect, not favorable, not unfavorable. And it would stand, actually, it really may, for individuals at risk for multi-infarct dementia, which is atherosclerotic, there may be some element of a favorable effect, probably not on Alzheimer's, but on vascular dementia. So.
Kind of have a follow-up question to that, and that is, how low do you go with the cholesterol following the guidelines before you change the dose?
Yeah. So the question is, how do we titrate, essentially? And that's a tough one. So let's say you have a patient who's post-MI, so he's at high risk, and you're definitely know he's at high risk, and he is now on 40 of atorva, and that's where he ought to be and you've got his LDL at 70. And I'll give you, that's pretty good LDL. We'll do it for other scenarios, but he's at 70, and then your colleague over coffee says, why don't you put him on 80? And then remember, when you double, you're going to get another 6%, 5 or 6%. So you're only going to take him down from 70 to around 60 to 65. And he has a history of having intolerance to 2 statins at high doses, but you found he can handle atorva 40. And he's symptom-free at this point. He doesn't have angina. That's a discussion with you and the patient, and versus also, would you add a second molecule? Now, there's, for instance, that's where ezetimibe came in. So 7 years of ezetimibe, you may favorably affect his risk. But there is no right answer for that patient. Now, but let's say the patient is 35 years old, and he's having active disease, and he's got 4 risk factors, and you're not having much, you're doing your best, but he's still having active disease. So I would for sure, in that case, try to go to the higher dose. I would go to the maximally tolerated, and I would give him what I would call a self-management discussion. And the way of self-management is, okay, Mr. Jones, you're on 40. We already know you can tolerate 40 with these other medicines. Let's have you go to 80 milligrams a day, okay? And first of all, if you start to have cramping or complaints in the first couple of weeks, it's probably not statins, okay? So especially pay attention 2 weeks to 6 weeks. Let's say you start to have trouble, 4 weeks out. It might be the statin, but maybe you did some more exercise than usual over the last few days, worked in the garden, something like that. So if you have trouble and you're getting myalgias, stop the statin. We call that a statin holiday, a 3 to 5 day holiday, and then potentially even restart it again. So he's helping with the titration. And the point is, when you stop at the 80, you take a break, and then you go back to the dose you tolerated. So he's self-titrating, okay, in between visits. We do this a lot. That's one of the things we do in lipid referral clinics. We don't ever titrate more than 1 dose. I would, for instance, if you had him at a lower dose, 20 of atorva, not quite so appropriate for somebody with coronary disease, but I would only go 1 dose, and we use ladder analogies or whatever. It's self-management. But if you're having, let's say the same patient, you had an incredibly good response. Do you really need to go further? We don't know. We really don't know. Now, if your LDL achieved was still much over 100, I would say for sure. So it becomes a discussion with each patient, what you think is appropriate, etc. We no longer have quite the issue. Is, let's say a colleague of yours, put somebody on Prava 40, post-MI. Or it was pre-MI, but then, let's say even post-MI, and the LDL 60. Are you going to trade it out and put him on atorva 80? That's a tough one. That's art of medicine, because he's already got a very low LDL cholesterol. So there's no right answer. It's an individualized
So
issue.
in a similar case, what if a young patient has had an MI, he's appropriately on 20 of cholesterol, you check the LDL and it's 27. Do you think, well, should I drop it to 10 or?
All right, so now you're talking about back titration. I would probably leave it there. I'd love to see that patient. It's pretty hard to get a patient with that good a response and be that low, but it is theoretically possible. The other thing I didn't mention, for the patients who are achieving the very low LDL cholesterols, I want to say I start at level 50, is I tell them to take a multivitamin. Not that we don't know if it'll cause any benefit, create benefit, but it certainly won't cause any harm. So with the fat-soluble vitamins. But that's mostly driven by just art of medicine again, no data.
One more
Just some practical information about the PCSK9 inhibitors. We probably prescribed them to over 100 patients in our heart disease prevention center, and so there are no REMS regulations. Anybody can prescribe these, but my suggestion would be just document meticulously as far as indications, drugs they've taken, if they're statin intolerant. You have to say probable heterozygous familial hypercholesterolemia. And then there's a fair amount of paperwork that goes along with this. The retail price is $14,000, but in reality, patients who are approved get a bridge for 3 months at the cost of $0, which is amazing. And patients have been paying co-pays anywhere from $0 to $50 a month, which is still amazing. Somebody's paying for these. But in reality, if you have a patient that meets the criteria, be aggressive about it and keep pushing hard to get them the drug.
Well, with that, we'll thank Peter for a fantastic talk to this show.
The preceding program is copyrighted by Emory University.